Maybe I'll just welcome everyone, and I'd also like, before we start, to acknowledge the traditional owners of the lands on which we meet, or at least where I am, the Wurundjeri people of the Kulin Nation, and pay respects to their elders past, present and emerging. Thanks for coming along, everyone. Other people may join us as we go along, but we welcome them, and yeah, welcome to the session.
Thank you.
Thank you.
Yes, I think Sarah mentioned earlier on, for anybody who joined us a little bit early or just on time, if possible, if you're able to change your username to your actual name and or organisation, that would be great, just so that we know who we have here and where you're from, or maybe put it in the chat if you're not sure how to do it. That would be helpful. So welcome. Today we have a couple of guest presenters from the Royal Melbourne Hospital. So thank you, Penelope, for teeing this up for us. We have Dr. Wendy Kelso, who is a senior clinical neuropsychologist, and Daina, who is a senior social worker. And so I believe they both work for the younger onset dementia program, Royal Melbourne Hospital. So thank you very much for being here, and I'll hand over to you to talk to us a little bit about your work in that program. Thank you.
Hi, everyone. Do you want me to start? Well, we work for the neuropsychiatry unit in the Royal Melbourne Hospital, which is not only younger onset dementia, but that is a big part of what we do. So I think we've sort of arranged the talk around younger onset dementia. Is that kind of what you guys want to hear about?
Yeah.
It's just one part of what we do. It is a big part of what we do, but we've decided to speak around that. Is there anything that you specifically want covered? We've got a little talk that we, as Penelope knows, was a little bit last minute, but when I rang her this morning. But is there anything specifically that you guys want to hear about, or should we just talk and then you can ask questions afterwards? Or
that's good.
Yep. I'm just going to share the screen.
Yeah, sure. All right. Thank you so much for having us. It's exciting to be able to talk to you today, and it'd be great if you've got questions, either pop them in the chat, but we're very, very happy to be interrupted as we go along, and people can unmute and turn on their cameras if they feel comfortable, and we'll answer as many as we can to go along. So I'll just get the slides up. Just give me 1 second. Okay, now can people see our slides now?
Yeah.
Yeah, great. Okay, that's good. So, yeah, okay. All right, so we're going to talk a little bit today about young onset dementia. Now, Penelope, can you see the slides in full screen?
Yes, I can. Thank you.
Okay, and it's the first slide, young onset dementia neuropsychiatry.
Yes.
Excellent. Now, before we start, can you see and hear us clearly?
Yes.
Excellent, that's good. You tell us at any stage if that becomes more difficult. Yeah. So we're going to talk today just a little bit about what is neuropsychiatry, and then we'll talk a little bit about our service and the role of assessing and managing a service of people with young onset dementia. We'll talk a tiny bit about just the different types of young onset dementia that are more common, but also some of the rarer types. I'm very happy to take questions about that. And then we'll include just a little case study, so you get a little bit of a sense of the type of questions we see and the investigations that a person would have if they come to neuropsychiatry, and then happy to take any questions after that. No, but it'll come up. So.
Okay. So this is just a little slide about the neuropsychiatry unit. We are part of Northwestern Mental Health, but we're based at the Royal Melbourne Hospital. We probably should have spoken a little bit about that. We've got a number of logos underneath that we're all sort of connected to, but basically we're a statewide service. So even though we're based at the Royal Melbourne Hospital, we are beyond the geographical locations that some hospitals in mental health services are kept to. So we don't have those. We see people statewide and also interstate. We have an inpatient unit of about 8 beds, which doesn't sound like much, but you know, anything over 6 means that we're quite busy due to the intensity of the assessments. And we have an outpatient unit as well. We're all based in the one location. So we have discipline-wise neuropsychiatrists, one neurologist, neuropsychologists, an OT, social work, speech, nursing staff, obviously, and sometimes we have art therapy. And according to this slide, we have approximately 100 inpatients a year. Our average length of stay would be, I would say, between 7 to 10 days, but there's lots of flexibility around that. Some people, particularly in COVID, don't want to stay very long, particularly during those times when they haven't been able to have any visitors. And then sometimes, depending on the issues, we've had people stay months, particularly if it becomes a placement issue. So we're not like a mental health unit where the average length of stay is much shorter and the pressure of beds is much higher. 750 outpatient appointments a year, and what's the 350 unique outpatient?
Yeah, so we'd see 350 unique patients a year. So a number of people that come to the unit would have multiple appointments per year. So for example, if you're referred for a diagnostic opinion as an outpatient, you would see a doctor first and then often a neuropsychologist, and you might see social work or speech, and then you'd have a feedback session after that, and then would have ongoing appointments with a clinician throughout that time.
So about 50 to 70% of the work that we do is around the area of younger onset dementia, but we also see, particularly in the inpatient unit, which is more of an assessment unit, I would guess, would be complex psychiatric disorders, movement disorders, other neurodegenerative illnesses such as Huntington's disease. We see a lot of people with Huntington's disease, Parkinson's, organic psychiatry. We can get a little bit more into that. And we also have a deep brain stimulation program. Probably, I'm not sure if anybody knows about any of that. It's a program for people with obsessive OCD, obsessive compulsive disorder. And we are an assessment unit to see if people may benefit from deep brain stimulation. It's not really related to younger onset dementia, but it is a part of what we do.
And I think we were part of a big telehealth project run through Better Care Victoria before the pandemic. Because we are a statewide service, a number of our clients have to travel a long way to get to the hospital. And probably a third of people we see are from rural areas across Victoria, but we also see people from interstate as well. So certainly throughout that project, we were looking at whether we could work out if someone had a diagnosis of young onset dementia via telehealth, both from a diagnostic point of view and feedback. And because that was able to be done, and we've done that with a variety of CADMS clinics across Victoria, we now offer that as ongoing part of our care, particularly during COVID. So if it's appropriate, people can elect just to be seen either via telehealth or face-to-face, depending on their personal preference. And then obviously for ward admissions, they would come per usual, but they may then also get their feedback via telehealth if that suited the family more, so they don't have to travel so much.
Yeah, I mean, I would say we would often now do feedbacks where we give information of what we've found during our assessments via telehealth, particularly if it's people from regional areas. The other thing is that we're doing more and more telehealth also, even if they're not regional or located a long way away, just because people whose carers still need to work, that can't take the time to travel. Parking at the Royal Melbourne is a complete disaster. It's expensive, it's never available. So we've sort of managed to sort of work that out quite well, and it does work reasonably well now using telehealth, as you will all know.
There's obviously a certain proportion of clients and families that either would prefer to be seen face-to-face or it would be much better seen face-to-face, and particularly for people that have movement disorders, for example, that might have some Parkinsonian features or tremor or other things that need to be seen in person. That's why we either get them into a face-to-face outpatient appointment or be seen on the ward. Yeah.
Can I just clarify, sorry, with the movement disorders, I mean, why would you see those instead like a neurologist? Like, do they have to be of a particular type of unique sort of situation? I don't know. I mean,
yeah, it might be where the diagnosis is unclear.
Okay.
We do get referrals from neurologists. We also have a neurologist that works with us.
A what, sorry?
A neurologist.
Okay, yeah. All right, that's fine.
I mean, yeah, a lot of like things like Parkinson's disease, we do see some people where the diagnosis ends up being Parkinson's disease, but the initial symptoms may be a bit unclear, a bit blurry. So we're really around diagnostic clarification.
Okay.
And Maria, a number of people that get referred to us where there's a question dementia would have changes to either sensation or movement, for example, or they may have what we call praxis difficulties, where they have difficulties using motor function or getting dressed or other things. So as part of their dementia, even people with frontotemporal dementia often end up having gait disturbance, or for example, there's some people that have motor neuron disease that go on to develop frontotemporal dementia. So there's a big overlap, and we'll show you those slides in a second. Yeah.
The other thing is that some people who have pre-existing psychiatric illnesses may be on medication that result in movement issues. And so sometimes it's difficult to know, is this from the medication or is there something else going on? Yeah. So coming to a unit like ours can help clarify some of those issues.
Okay.
So Maria, for example, people that have psychosis or schizophrenia, a lot of thought disorder, will be often put on antipsychotic medications. And those type of medications...
Parkinsonism, yeah.
That's right.
They get our service. What I'm saying is we see a lot of people with those sort of conditions. Like I've seen a lady this morning with our psych registrar where she's got schizophrenia, but she's developed really terrible side effects, and we're titrating her medication. But what I'm saying is it wouldn't come straight to neuropsychiatry, those cases, because they go through other channels first.
Yes.
Yeah.
Often we're kind of the end of a journey.
Yeah, yeah.
So
yeah,
Maria,
I've had experience with you guys in the past, and we've actually got one of your patients in our ward, a lady with Huntington's, that was recently referred to us. So I've had experience with a little bit of experience with the neuropsychiatry unit. Yeah.
Where do you work, Maria? Sorry.
The Aged Person's Mental Health team at the Peter James Centre.
Oh, I know who that is.
Yeah.
Okay.
So there'd be quite a lot of overlap, Maria, in terms of the type of clients that you would see and the type of clients that we would see. We probably tend to see people a little bit younger, but certainly people with schizophrenia that would have cognitive side effects or difficulties with movements would be seen generally via mental health service first, and then if they were considering that something else was going on or concerned, then they tend to refer to us.
Sure.
Yeah.
No, we might just move on.
Yeah, we'll just go to the next slide. So this is really just about, we did a big study just to see really the burden of travel for people that we were seeing, and working out just how far people actually travel to visit our service, and how many specialists that they saw before they came to us. So a lot of people with young onset dementia, it takes a really long time for them to get a diagnosis, about 3 to 5 years. And just what you were saying, Maria, is they often see a number of teams first before they're eventually diagnosed. So this is just about how we diagnose young onset dementia. And for people that are over 65, the most common pathway is that they would see their GP. They would often talk to their GP that they may be having some concerns. Usually with their memory is probably one of the first things that people would talk about, particularly in a slightly older population. And the GP would refer to a CADMS or a memory clinic, depending on what state you're in. For people under 65, though, that's a little bit different, and often they'll go to their GP, and memory isn't always the first symptom that people complain about, depending on the type of dementia. It may often be things that are related to mood or anxiety or a brain fog or finding their concentration's not quite as good, or other unusual symptoms that the GP wouldn't necessarily think is something such as a progressive cognitive illness such as the dementia. So the vast majority of people that complain about cognitive problems don't have dementia, and so the GP would usually think about depression as the first consideration, or anxiety, and start them on treatment for that often. And then it's only after that if they fail to respond from that treatment, or there's other things that start happening. For example, they start having difficulties finding words, or they have some difficulties with spatial problems or other things, or significant personality change, or cognition progresses, that often then the GP would think, well, maybe this isn't a mood illness or a anxiety disorder, and or psychosis, for example, and maybe there's something else going on, and refer for more further investigations.
I reckon one of the big things that we see is that it's when people, because obviously people who have younger onset dementia are still in the workforce, it's when they find that they're not performing their work as they once were. And that's, I think, often one of the little telltale signs.
So these are things that often clients have sort of spoken to us about, that a lot of people, they don't get a diagnosis early just because it's, I think there's now growing awareness in the medical community about young onset dementia and different types of neurodegenerative conditions. And when we talk about neurodegenerative, we're really talking about neurological or neuropsychiatric illness that gets worse over time, such as frontotemporal dementia, Parkinson's disease, MS, Huntington's. All of these are neurodegenerative conditions. And it's not as easy as if you break a bone, you get an X-ray and you can see that something's broken, but it is quite complex trying to diagnose someone that's got different, everyone's got their own individual history as a person, and they may have had early life trauma, they may have had a learning disability, they may have English as a second language, they may have had a history of significant psychiatric illness. That doesn't necessarily mean that they won't go on to develop a neurodegenerative condition, but you can see how it can be harder if they've got a background of complexity, like lots of people do, to try and work out which bit you attribute to which and see if there's progression over time.
So often when we talk to patients and we're giving feedback, for example, so they might have come into for an outpatient appointment, or they've come in for an inpatient stay, and we all get together at the end as a team with the patient and the family if appropriate, and we talk about what we've found, if there, and sometimes there's a diagnosis and sometimes there's not. But when we talk about it to the family and the patient, we often talk about it as the piece of the puzzle. There's no blood test or X-ray that you can take to diagnose dementia, particularly in younger people. So we do all sorts of different examinations and we have to put it together like a puzzle. And, we're not always right. But that's how we sort of talk about it, or that's how I talk about it with patients and the families as well, that it really is pieces of the puzzle that we're trying to put together. And the pieces of the puzzle, if you can see from this slide, include, I think number one is the story. So the history from the person with dementia, and also depending on their level of impairment, the people around them. So we'll talk to family, we'll sometimes talk to employees if we've got consent. We talk to as many people as possible to really try and get a lengthy history. It's not like, I've worked in emergency departments before and you might have 10 minutes to get a history. It really is probably the biggest part of the story, I think. Examination by a doctor, if need to be an examination by a specialist, such as a neurologist that we have, neuropsychologists like Wendy, more often than not, will be involved to do assessments. They're a big piece of the puzzle. OT assessments are really, really important to look at function and also to look at the history from what's happening at home, and then to assess what they can do in the ward. So the OT might do some cooking assessments or the navigation assessments. That's a really important part. Blood tests, imaging such as MRIs and PET scans, and other genetic testing. So we don't always get those results back before the patient is discharged, but we always get an idea. We can put it all together like a puzzle.
And I think the reason why people often get referred is, and as Marie was talking about before, if it's really clear, so say you see someone who's 40, for example, and they've got a very clear history of memory difficulties, and they have a scan done and the imaging looks like Alzheimer's disease, then it probably is going to be Alzheimer's disease. But there's ones that are more complex where they may have more of a psychiatric presentation, or there's things that look a little bit atypical that you wouldn't necessarily think are consistent, that those type of people often tend to be referred onto a specialist service. And I think that's where, I think the basics, obviously, for a diagnosis of dementia in a young person is obviously a full blood screen to see if there's anything reversible, because that's probably the first thing they're looking about. You know, could this be an autoimmune condition? Could this be related to thyroid? Is there a depressive illness on top of this? You know, things that could be treated. And then once we've excluded all the treatable things, see what's left. They definitely need imaging, and I think both structural and functional imaging. So an MRI, for example, which is a static picture of the brain, and also functional imaging such as a PET scan, where you're looking at blood flow and glucose uptake in the brain to see what areas is getting proper blood flow or what area is not, and that's diagnostic. We also now give a blood test for everyone because we're part of a research study called the MIND study, which is looking at what's called neurofilament light chain. As nerve cells break down or are destroyed or the cell death, something called neurofilament light is what's a biomarker that happens. So once a cell breaks down, this is released into the cerebrospinal fluid, and there's an actual marker that we can now measure to look at the level of neurofilament light chain. And so Daina Aratni and Dennis Velikous, who are the psychiatrists here, and the other members of the team are running a study to look at that in people with psychiatric conditions and also with different types of dementia to work out if that's going to be useful for diagnosis, and we think it is. So for a lot of people that may have schizophrenia, which is a chronic condition, but doesn't necessarily deteriorate over time, often the question we get asked is, well, is this a dementing condition or is it a psychiatric condition? And this neurofilament light is extremely elevated in neurodegenerative conditions, such as conditions that are progressive, such as MS and motor neuron disease and Alzheimer's disease and FTD, but is much lower in people with depression, for example, or in bipolar disorder, which are static conditions. So those type of biomarkers can be really useful to differentiate, is this a progressive dementia or is it related to a psychiatric condition?
Yeah, that's really good. What did you call this test?
Yeah, so it's neurofilament light chain, so NFL it's called, and we can send you some more information. I know that Dharma is always recruiting people to be part of these studies, but he's very happy to talk as well about these type of things. So it's at this stage, it's still being used as an experimental blood test, but they're hoping that it will be used in the future for diagnosing dementia much more commonly. Yeah. So it means that hopefully people won't have to go through all the extensive investigations, and they'll be able to have a blood test. It's not diagnostic in terms of the type of dementia, but it will be useful, we're hoping, to differentiate people with either a psychiatric or a functional condition versus people with a progressive neurological condition. Does that make sense?
Yeah.
Yeah. So, for example, if people have motor neuron disease, sometimes neurofilament light can be, sort of 2000s, very high. But people, for example, that don't have motor neuron disease might have levels, in the 600s. So they're working out what's normal for someone that doesn't have a neurodegenerative condition, and then what's really abnormal. And the more significant the condition is, so motor neuron disease obviously affects people. It's a very fast progressing condition for some people, particularly if they have frontotemporal dementia with motor neuron disease. So and vasculitis and CJD, conditions that can progress very quickly with dementia. You're getting loss of neurons more quickly, hence the neurofilament light is much more elevated than in conditions that are more slowly progressive. Does that make sense?
Can I just ask you, do you see a lot of people, you're talking about the motor neuron, the FTD, do you see a lot of people with the C9orf72 gene?
Yeah, look, we do, Maria. I wouldn't say heaps and heaps.
I wouldn't say a lot, but a couple a year.
Yeah, we had one of those, and he was a diagnostic challenge. Finally, yeah. Anyway, okay.
Maria's talking about a type of frontotemporal dementia called C9orf72, where the C9orf is a genetic mutation, and often these people have a slower progression of frontotemporal dementia over many decades, and often it's personality change, but it's also associated with motor neuron disease. So a number of these people go on to develop both motor difficulties as well as more personality and behaviour change. So I'll move on to the next slide, if that's all right.
Just looking at the time as well.
So we've talked about the history. Look, I think the history is actually, in all dementia diagnoses, is actually the most important, because really it's getting a good sense of what are the pre-existing factors in the person's life, but also was there anything around the time that the cognitive difficulties started that may be impacting? So, for example, we see a lot of people that complain of cognitive difficulties, but they've had a very recent significant death or loss in the family, or there's been a major medical event, which is the reason why they're having cognitive difficulties rather than dementia. So taking that history is really important, but also working out, you know, is this someone that's had cognitive difficulties since they were in their early 20s, versus is this someone that's been working in a highly functioning position, but just in the last couple of years, there's been a marked change. That can be really helpful in terms of the diagnosis. We were talking before just about examination by a doctor, and that's the reason why they're trying to rule out nutritional deficiencies, if they've had strokes, if they've had other type of things, rather than the dementia. And also the reason for referral. So we get a whole range of reasons for referral here. The vast majority of the work would be diagnostic, but we also get referred people that have got a diagnosis of young onset dementia, and they need a supportive service to support them over time. So I think the biggest issue for people that are diagnosed with dementia is that they often don't have good supports available after the diagnosis is given. And I think that's where Dementia Australia comes in, and a lot of other support agencies that are working now much more actively to provide post-diagnostic support. Because for a lot of people, they thought there was a massive difference between all this time was spent getting a diagnosis, and then they were left in the wilderness a little bit once they actually got the diagnosis. And I still think that's an area that requires a lot more time and investment through the government, is the post-diagnostic support once the diagnosis has been given, because that's when really the difficulties often start for the family.
I will say another reason for referral that we sometimes see people is that they might come into our unit either as an inpatient or an outpatient, and they may not fit the criteria for dementia, but we can't completely rule out that it won't happen in the future. So rather than them sort of going back out into the community and wondering what's going to happen, we can say, look, we can follow you up in 6 months or a year or 18 months so that they can come back, so that they can go away knowing that if things get worse or they don't have that cloud of uncertainty, they can come back and we can assess them again.
I think it's also worth acknowledging that, particularly for young onset dementia, some people will be given what's called a provisional diagnosis, which means that they don't meet diagnostic criteria to get a definitive diagnosis at that time. And we think there's probably something going on, but we don't have enough evidence yet to be absolutely definite. Now, between the categories of what we call, you know, normal cognition, where you don't have any cognitive difficulties, to mild cognitive impairment, to dementia, there is transition across some of those categories over time. And for a certain percentage of people, it won't be very clear until they've had serial assessments over a period of at least 12 months to see if there's progression over time. And sometimes people will be told, look, your imaging looks like you've got early onset Alzheimer's disease, for example, but you actually don't have any memory difficulties at this time, or there's not enough to actually give you a clinical diagnosis. But looking at some of the imaging, looking at the biomarkers, it may be that you're more likely to develop Alzheimer's disease in the coming years, or that they have a family history, a strong genetic history of dementia. They come for what we call predictive clinic, where they would come to be screened to see if they do or don't have the gene, and whether they're in a fit mental state to actually decide whether to have that decision. So quite a lot of our work for both Alzheimer's disease and FTD, but also for Huntington's disease, where there's known genes involved, is families being referred because they would like to consider getting genetic testing to see if they themselves have the gene. And then we would follow these people over time. So we see a lot of people that are what we call gene positive but pre-symptomatic, no symptoms yet. And then we use cognitive testing and imaging to work out when they're more likely to be symptomatic so they can help plan their life. Because if people are working or deciding to have children, particularly if they know that they've got a gene themselves or they may be at risk of inheriting a gene for dementia, it's really important before they make the decision to have children that they know the options available through IVF and pre-implementation genetics, you know, and embryos if they would like to go down that path.
I'm sure you will be very familiar with all the stuff that we're presenting, so we don't want to sort of tell you what you already know, but we all know that younger onset dementia is difficult to diagnose because we don't expect to have dementia in a younger person. Although, of course, there is a little bit more awareness these days, and it can present differently to that seen in older people. And as we were talking before, it's often diagnosed as something else, or we're not sure what the chicken or the egg is. Are they depressed because they've got these symptoms, or is it just dementia, or is it just depression? So it's often, I wouldn't say misdiagnosed, but it's often just the depression that's seen. And a number of rare and less well understood conditions can also cause dementia.
And Maria, I think Maria was mentioning before about C9orf in terms of one of the genes that cause frontotemporal dementia. And I think this is one of the difficulties in young onset dementia, is that over time people can develop more symptoms and where there's a big overlap, and therefore I know that Dementia Australia gets a lot of questions from families and people with dementia asking me about different symptoms and also for diagnostic clarification or even for second opinion, because someone might be diagnosed, for example, with either mild cognitive impairment or Alzheimer's disease, you know, at time 1, and then they go on to develop a significant amount of motor symptoms or behavioural change, and then that diagnostic criteria is changed and they're actually diagnosed with something else. So there is, I reckon, probably at least 20% of people that we would see that diagnosis could shift over time. And that makes it quite difficult, particularly for NDIS, where if they get a provisional diagnosis where they may not be able to get access to get funding until there's a definitive diagnosis of dementia. I know Penelope and I have talked about that before, where it's a real issue for people, is that having a waffly letter, you know, from a specialist service saying they may or may not have dementia is not particularly useful, you know, when they're trying to get funding in the community. And it's also not very useful for people that are working with people with dementia or support services of people with dementia. They needed some clarity regarding about their dementia, but also the symptoms and also prognosis, because they're the ones that are going to have to educate them and support them in the community going forward.
When you look at the dementia classifications, you can have, you know, probable dementia, which means that the person has a lot of the symptoms of dementia and they're impaired and they need help. When NDIS read a diagnosis of probable dementia, they're like, well, this is, you know, this is not permanent, or this is, you know, I want a definitive answer. So I tell the doctors, just don't do any of that stuff, just be blunt. And just say they have dementia. They don't need to know the classifications because it's not helpful in terms of getting access to NDIS. Would you agree, Penelope?
Look, I think the difficult thing is that in terms of the different types of dementia, some of them have very different cognitive, language and motor symptoms. And sometimes it's an academic exercise in terms of the different types of dementia for a diagnostic point of view. And look, that is important to get the right diagnosis, because then you can inform the family about prognosis and also the risk of different types of genes involved and other things. But once people have sort of moderate to severe in dementia, that really is not as useful. And it doesn't actually matter as much the type of dementia. It's really more about supporting the person to live the best quality of life they can and about function. So I think sometimes people get caught up in, you know, is it logopenic, like a language variant of Alzheimer's disease, or is it, you know, this, that and the other, when really it's, if that isn't that important for the person and living the best quality of life, I think probably it's more about supporting the person to live their best and being able to compensate for the cognitive or motor or language difficulties that they actually do have.
Yeah. What are the youngest people that you see, like do you see, because I think once I was told you have people in their 20s that are diagnosed
With younger onset dementia.
Yeah, that's right,
So
Maria.
30s, we've seen lots of people in their 30s.
Maria, probably the people that have very young onset, like late 20s, early 30s, tend to have a genetic history.
Got a family history.
Yeah, so tend to have a family member that has a known gene involved, not always, but often. And some of those people are also diagnosed before they're very symptomatic because there's a known family history. But we did see someone that was probably 28 with frontotemporal dementia, no family history, and he passed away probably about 8 years later. So it can be quite quick, particularly if you're diagnosed young. It does tend to be more progressive illness, particularly if there's got a genetic variant. It can progress more quickly than people that get it in their, for example, their 60s. So it depends how aggressive the illness is. Yeah, and look, it is highly variable, and I think that's one of the hardest things is we get asked a lot about, well, what's the prognosis? How many years am I going to live? What's that going to look like? And we always say vague things. Well, look at how it's been progressing so far. That's likely how it's going to progress in the future, which is probably true. Is if it's been slowly progressing, it's probably going to be slowly progressive going forward. And if it's been rapid, but once people start to develop significant what we call bulbar symptoms, which means difficulties with swallowing, or they have any difficulties with aspiration, you know, food and drink going down the wrong way, that hastens mortality. So, or they have a lot of motor difficulties as well. That once that starts to happen, it does tend to mean that the diagnosis is shorter. So, for example, someone with Alzheimer's disease that's diagnosed at maybe 65 or 70 that doesn't have a lot of motor or speech changes will probably live a longer life than someone that's diagnosed with motor neuron disease, where the average lifespan, you know, particularly if you've got frontotemporal dementia on top of that, is sometimes between 18 months and 3 years. So really big difference in terms of, you know, how long the person may live. Just wanted to quickly talk about this diagram. So you can see these are all variants of different types of dementias, but are all sort of considered under frontotemporal dementia umbrella, apart from logopenic variant, which is basically language variant of Alzheimer's disease. And each different type of dementia has a different cognitive and language profile and motor profile. And that's why it can be really difficult, because there's a lot of overlap between the symptoms. So often people with corticobasal degeneration, which is considered an FTD, often they present actually with language difficulties first. And so they may be thinking that it's Alzheimer's disease, but then they quickly go on to develop some motor symptoms. It looks like Parkinson's disease, may become quite apraxic, or may have difficulties using a limb, which is called an alien limb, where they, you know, their hand actually does work, but they can't make it work. And it's a little bit like a dead weight. So you can see there's a huge variation, but also overlap between the types of dementias that you see, even under the one umbrella type of dementia.
Yeah. Can I just ask, you know, the younger onset is like 65 and under. Often, as we know, the dementia is there for many years before it's diagnosed. So it's the point of diagnosis that makes it, whether it's a younger onset, not the time that it actually started to emerge. Because, I mean, it's just an arbitrary point, 65, but we know that a lot of people, if you look back, there's years where there was deterioration that the family tried to explain for other reasons. So I just find that age 65, like everything over 65, it's not regarded younger onset.
Yeah, I think one of the reasons that sort of exists is actually for service provision.
Okay. Yeah.
But yes, it is an arbitrary point. But yeah, I mean, so for example, because we're under 65, it's NDIS, and then over 65, you know, I had someone the other day who was she had Huntington's disease actually, but she was turning 65 the next day, and the family hadn't been given the diagnosis yet, and they couldn't get the family in. So I rang NDIS to say, anyway, the point is that NDIS would not accept a referral one day after the patient turned 65.
And Maria, we would consider it young onset dementia if the symptoms start before 65.
Yeah.
So not when the diagnosis is given, but if you have symptom onset before 65.
I mean, that is helpful for families in terms of whether there's a genetic link, but I think really it seems to have come about for service provision. But yeah, we would consider younger onset dementia if the symptoms started before 65, which is often the case anyway.
It's still really hard with aged care assessment teams because we still really struggle getting ACAS assessments for people under 65.
Just about impossible, isn't it? Just about impossible.
You really have to, I mean, there's, yes, you really have to explore every NDI. You have to exhaust NDIS to its absolute limit.
So we thought we'd just go through, we've got about 15 minutes left, just a little case study quickly, just to give you a sense of the type of people we see here and also why they might be referred.
Can you do this page?
Yeah, so this is a lady that's been admitted to the ward, you know, reasonably recently, a 50-year-old lady of probably average pre-morbid intelligence that was referred for a cognitive investigation by the GP. Because she had some complex psychiatric symptoms, but also cognitive problems. The client themselves was complaining about cognitive problems, but couldn't really give a very good history. But the husband had noticed a significant decline in cognitive function over a number of years. And this person worked in retail, but there was a workplace accident, you know, a number of years ago involving a forklift, and they were injured quite significantly and had ongoing sort of pain, back pain, and ongoing psychological issues since that accident, with a little bit of trauma and sort of post PTSD type of symptoms from the accident. But there was also ongoing compensation claims as well about whether they were going to get money, you know, in terms of get a payout or having income protection kick in. So there are a number of factors that were related to that were making the diagnosis a bit more complicated. And the client was also saying having delusional thoughts. Well, and people weren't actually sure if they were delusional or not, that the husband was having lots and lots of affairs. Not to the point where the client was considered psychotic, but there did seem to be some evidence of thought disorder. And then had a Cadham's assessment about a year prior to being referred to us. And at that stage, the Cadham's had thought that it was probably related to depression and anxiety with significant what we call functional overlay, where they didn't think the client was actually putting in full effort and were concerned that the client was potentially emphasising their symptoms to make sure that they continued to get ongoing compensation from the workplace accident. And was told that they had a blockage in the memory due to sort of emotional distress. So really the explanation was given that this is related to, you know, depression really, rather than a dementing illness.
But I think Cadham's there was enough question mark over that for them to refer her to us.
Yeah. This lady probably looked older than her years and was reasonably neatly dressed and groomed when she was on the ward, and there was no evidence of sort of motor or gait difficulties. But when she was seen, had very significant difficulties with speech, where lots and lots of word finding difficulties with a lack of detail and tendency to forget what she was saying during conversation. So, for example, she had a quick chat to me, showed me a photo of her pet on her mobile phone, and then 3 seconds later showed me the same photo of the same pet on a mobile phone, and actually had just forgotten, you know, 3 seconds before about what she was actually showing me before. And really evidence of rapid forgetting in conversation.
She actually comes across as quite flat and low in mood, which she has a history of, but it's difficult to know whether that's because she's actually finding it very difficult to contribute to the conversations that, you know, I might be having with her husband, who's here very often, and so she actually doesn't know how to contribute anymore, so she just comes across as quite flat.
This is someone that was a little bit resistant to being assessed as well, that was in her bed a lot on the ward and refused to be interviewed by some of the doctors, and was seen a little bit as someone that was probably more complex to develop rapport with and complex to assess. and hence they weren't sure whether that was due to psychological factors or if it was due to some of the cognitive difficulties. But it became increasingly clear during the length of her admission, and just because we had all the behavioural observation of seeing someone in a ward environment, that actually she was increasingly anxious about how to get home. She was very anxious that her purse or her handbag had been stolen, that, you know, someone had stolen her car, and really because she'd forgotten where these items were, which obviously is very common, you know, when you're seeing someone that's developing a dementia condition. And when she was asked just about whether she'd like to call her husband, she said that she's, you know, that he was probably with his girlfriend, and that her husband had about 4 different girlfriends, which was all actually delusional content.
Because he was driving long distances to be with her every day on the ward.
So this is someone who's in some ways a little bit easier to diagnose, because by the time we saw her, she was very cognitively impaired. But I think because there seemed to be some discrepancies between her level of function at home and also her level of function on the ward, she actually is able to do very little. But I think people, because she was so young, thought that possibly she wasn't doing enough really for either secondary gain measures or that there was a psychological overlay. But really, she knew her date of birth, but was otherwise extremely disorientated on the ward. Her attention fluctuated quite a lot during assessment, but she was frequently really quite confused and required redirection and prompting all the time. And on cognitive assessment, sort of more formal cognitive assessment, had very severe language difficulties, so what we call anomic, just couldn't get the words out. Very severe visuospatial difficulties where she could only really copy a triangle, couldn't copy a bike, couldn't copy a cube, couldn't copy any even more basic things. And really had the difficulties where when some people have difficulties copying, they try and trace on top of the drawing, you know, rather than copying it beside, because actually just have such significant visuospatial change. And when she had some functional imaging done, she had very clear what we call hypoperfusion, so lack of blood flow in the temporal lobes, which is the area responsible for memory function and language, and also in the parietal lobes, which was responsible for sort of visuospatial skills. And in a profile like that, with someone that probably has sort of moderate Alzheimer's disease, that's very common that people, particularly when they're younger, may have more of a psychiatric presentation where they do develop some paranoia and often mood, you know, there's a huge overlap between people that have dementia and also have depression. But I think because of the, she was often quite teary and labile as well, and because of the upsetness, people had mistakenly attributed her psychological distress to other factors rather than the fact that she had such severe cognitive impairment. And this is just a little picture just about what's normal neurons, and then looking at Alzheimer's disease, just looking at the pathology, neurofibrillary tangles and amyloid plaques. So often people on the ward would have basically lumbar puncture, looking at cerebrospinal fluid to see if Alzheimer's proteins are elevated in their CSF, or now sometimes we can also do that in a simple blood test. And that's quite diagnostic for about 95% specificity and sensitivity for Alzheimer's disease. These are common difficulties. You can see tau tangles, and often people have tangles as well in the posterior cingulate cortex. And you can see here just changes in the brain with Alzheimer's disease. So this is the hippocampus. I don't know if you can see my mouse, but where the little arrow is in a normal brain. And then you can see with significant Alzheimer's disease, there's a severe shrinkage in the memory center of the brain, but also in the parietal lobes, which is responsible for you know, calculation and finding your way around, and also estimating time. So, you know, is it 10 o'clock or 2 o'clock? Estimating how much things are worth, and also doing practical things like judging, you know, stairs. So when you're walking up and down stairs, you know, clearing stairs, those type of spatial things, going left and right. If you're sitting down, judging how close the chair is to you or where to put your body in space, as well as some of the clear memory and language changes that happen in Alzheimer's disease. So they're the tests that we did. So she really had the full gamut of things done, as you would expect. And this is where to from here?
Yeah, so this would be if someone was newly diagnosed with a dementia of some description, this would possibly be the path that most people that come to us would be given. So they'd be offered the opportunity to be linked into our outpatient clinic, or they can also choose private practitioner if they want to. Some people don't want to come back here. Some people want to see someone in person, so they try and find a private practitioner where they're based, so that if they don't want to do telehealth. Majority of people choose to be linked back into our outpatient clinic. It's much better continuity of care, I think. And in our outpatient clinic, we can do all the medical monitoring, or the neuropsychiatric monitoring, which is medication, symptom management. We offer support to residential care. So sometimes our doctors will talk to some of the providers in residential care about management. I know there's other services that do that as well, because we all can also refer to DA, Dementia Support Australia, APAC, those sort of things. But often our doctors or sort of other members of the team can talk to staff about progression of illness and some medication management and other ways that we can help support them to support the patients. Social work is a reasonable sort of part of outpatients, because often when people get a diagnosis on the ward, they'll get the diagnosis and they might go home that day or the next day. But it's really when they go home that the social work supports need to happen. So social work will continue to liaise with the person, even if they don't want to be linked in with the outpatient clinic, but just to get them set up with referrals in the community. And they may also come back for further neuropsychological testing in the future.
I think the outpatient clinics and that sort of model of care from pre-diagnosis right through to the end of the journey of dementia. So often then it's much more about symptom management, about cognitive interventions, speech and language and communication strategies.
Family support.
Yeah, Daina will do a lot of work with the family, doing some family therapy and, you know, other things, managing the practicalities of supporting the person, occupational therapy strategies to manage.
Yeah.
So look, I think we'll should we end there, Penelope?
Because we've got 4 minutes.
Yeah, so people can ask questions. I'll stop sharing.
Thank you. Very interesting.
Oh, thanks, Penelope. Well, you've probably heard it all the time before, but still, yeah. Has anyone got any questions?
I just wanted to ask, do you think that referrals are starting to come through from other sources now, like not only your CADAMS clinic, and it's terrific that they do, but perhaps from GPs, your community GP? You might be seeing more of that.
Yeah.
We definitely are, Penelope, and I think it's actually interesting. We were talking at a conference last week just about there's been a big increase in referrals since COVID, I think, because a number of people weren't able to access their usual care or were tentative to access usual care during COVID for a variety of reasons. And across all specialist clinics, not just neuropsychiatry, there's been a big increase in the number of referrals, but also people with what we call functional cognitive or neurological conditions. So not necessarily dementia, but people that have had a lot of anxiety or depression during the pandemic and are now quite concerned about their cognition or attention. And there's a lot of people, if you've been on Zoom meetings all day long or seeing therapy clients, you know, via Zoom, everyone's finding that their attention is not as good as it was because it's so draining. And to do assessments and therapy, I think for the clinician, it's much more attentionally demanding via a screen than it is face-to-face. People being concerned, and also just that their brain isn't working as well. They've got brain fog. They haven't been sleeping as well. We've seen a very big increase across all clinics, private and public, with those type of complaints by people that really haven't had any sort of psychiatric issues before, but now are concerned about a variety of different things. So that's going to be the next wave, and also people that have actually been infected with COVID, because a number of them will have ongoing cognitive and motor symptoms going forward, or neurological symptoms, and they're working out whether if you've had COVID, like quite significant, and been quite sick or hospitalised with COVID, whether you're more likely to develop a neurodegenerative condition such as Alzheimer's disease in the future. And they're thinking that that is possible. So there may be more people probably more likely overseas than in Australia. But we will get people coming to clinics as well that have had COVID, and be worth thinking about looking at the severity and to see if they've got long COVID and any sort of ongoing kind of psychiatric or cognitive symptoms going forward.
So they're keeping that quiet.
They are, yeah. Hence,
Well, no, it's in the media, because my husband has indicated to me that people, particularly the ones that have lost the sense of smell and taste, they're the ones that are likely to have the neurological issues as they age. So interesting. Tell me, you know, the Eastern Cognitive Disorders Clinic, I mean, because we refer some tricky clients to them as opposed to you guys, because I think, well, they're part of Eastern Health, and that there is a bit of an overlap, although they don't have an inpatient unit as such.
No.
Yeah, Maria. Look, Amy Brockman and David Darby work in the Eastern Cognitive Disorders Clinic, and we work quite closely with them as well. We're all part of similar sort of professional support groups. Really, it's often geographical. The main difference, as you say, is that that they don't have an inpatient ward. So if you need, particularly for people from rural areas, sometimes they would prefer to get everything done in the one admission rather than have multiple appointments back and forth. And we probably tend to get, Maria, more people that have got a psychiatric or a depressive, just because it's a psychiatric service. An Eastern Cognitive Disorders Clinic probably tend to get more dementias where there's a language variant, just because of the nature of the ways that the referrals split. But there's a big overlap, and essentially the type of investigations that are done at both are identical, really. Yeah.
Okay. It's 4 o'clock by mine.
Everyone's looking a bit screen.
Yeah. Thank you very much.
Pleasure.
Yeah, lovely to see you, Penelope. Thank you.
Yeah,
Thank
you
so
too.
much for having us.
Thanks, Sarah.
Thank you.
Thanks.
Thanks,
So,
everyone.
thank you very much.
And thanks for the great questions, Maria.
Sorry, because I hope I didn't monopolise all the question time. It's just, yeah.
I know we like questions.
It's always good to have someone in the audience and ask questions, Maria. We enjoy that. Yeah. All right. Thank you so much.
thanks, everybody.
Very much.
All right.
Bye-bye.
Thank you.
So, Sarah, I'll send you their email addresses.
That'd be great. Thank you.
That would be good,
Okay.
actually. Yeah, I would. Will that go out to the whole group? Because I wouldn't mind having them. We've had some mutual clients over the years, and we've currently got one as well. So it would be good to be able to have their email addresses.
Yeah.
Okay, wonderful.
Yeah, they're a great service.
Yeah.
Oh, thanks, Penelope. Thanks for teeing that up for us. And if anybody else has any suggestions or ideas of guest presenters, please shoot them our way. Sarah and I are always on the lookout for more people, but otherwise.
We've got someone.
Sorry. Go on.
No, I was just going to say, if we got someone for the next meeting, I'm sure you've got someone lined up.
I don't think we have.
Oh, okay.
Yeah, we had a few people that are less available as the year goes on. So I'm not, Sarah and I need to get our heads together and sort out, who's slotting into which month. What did you have a suggestion, Maria?
Just about a carer support group. I know years ago I attended something that Villa Maria was trying to get off the ground for a younger onset support group. And I know Dementia Australia, I mean, I don't know what's happening in terms of support groups for carers.
We have a frontotemporal dementia support group, right? So that's at the moment run on Zoom, was face-to-face.
Right, okay.
So that's the only formal group that we run. We just took it over from the Frontotemporal Lobe Dementia Association, I think FTA. We took running it over from them some time ago.
And Maria, we know there isn't a formal group for carers of people with younger onset dementia, but I've offered in conjunction with Elizabeth to set one up if we get any interest in one. So if you do have anyone who's interested, please just email me.
Okay, great. All right, wonderful. Well, Thank you.
Thanks very much.
Thank you.
Thanks,
Bye now.
Bye-bye.
Bye.